Hello, welcome everyone. I'm Dr. Charles Liu, a senior member in thoracic medical oncology here at Moffitt Cancer Center. Thank you so much for joining us this evening for an information-packed webinar. I'm hopeful and confident you'll find value in what my colleagues and I have to share with you. Before we begin, some housekeeping. Just wanted to remind the audience that the content is not intended to be medical advice, and the viewers should consult their physician should they have any questions. The viewers should not rely on information contained in this webinar for immediate or urgent medical needs. Additionally, if you think you have a medical emergency, please call your physician or go to the nearest emergency department or call 911. Never disregard professional medical advice or delay seeking care because of information contained in our presentation. Again, we're so pleased to have you here with us tonight. We'll share more on these exciting breakthroughs throughout the evening, starting with our first speaker. Before I introduce our speaker, I want to remind you that after we hear from our speakers, you will have the opportunity to have your questions answered by these experts. We invite you to type your questions into the Q&A box located at the bottom of your screen. Now on to our first presentation. I'm pleased to introduce Dr. Jobelle Baldonado, a thoracic surgeon here at Moffitt Cancer Center. She is an expert on initiatives involving new innovative surgical techniques for lung cancer. Dr. Baldonado, take it away.
Thank you, Dr. Liu. Good evening, everyone. I would like to thank the Foundation for this opportunity to speak to our patients, our caregivers, and our donors for this year's thoracic webinar. My name is Jobelle Baldonado. I am a thoracic surgeon here at Moffitt. I specialize in lung cancer surgery. My talk tonight will primarily focus on early-stage lung cancer and what we do as a thoracic surgery team to address this with curative intent. Next slide. So let's start with the scope of lung cancer. This chart here that you see shows some statistics from 2022, but it's really reflective of how it's been for many years. So globally in 2022, about 9.7 million people died of cancer. And among this, 1.8 million died of lung cancer, which translates to about 19% or nearly 1 in 5 cancer deaths worldwide. In fact, there were more deaths from lung cancer than colorectal and liver or colorectal and breast cancer combined. And although the incidence is somehow declining due to reduced smoking and better screening, it remains the deadliest cancer worldwide. And remember that each number in this figure is a person, someone that you may meet at Publix, for instance. Early detection can change this. Next slide. And while smoking in the center causes up to 80% of cases, about 10 to 15% occur in never smokers. And this may be due to environmental exposures like radon exposure, for instance, air pollution, secondhand smoke exposure, asbestos exposure. If you can click on that video on the top right, please. So this is from one of my patients. You can see there is a lung cancer in the very topmost part. But more importantly, I would like to show you that she also has emphysema. So it's those dilated air sacs there that you can see. It's not normal. These structural changes caused by smoking predispose one to having lung cancer. And then on the lower right, there's genetics. So family history increases the risk of lung cancer, especially in never smokers. So you see here that virtually anyone with lungs can get lung cancer, and nobody deserves it, smoker or not. Screening is the way to catch it early. Next slide, please. So how do we screen? Well, lung cancer screening was based off of this landmark study called the National Lung Cancer Screening Trial, or NLST. This study was published in 2011 in the New England Journal of Medicine, and this was funded by the NCI. It was multi-institution, and it was in 34 centers with Moffitt Cancer Center included, randomizing about 53,000 patients who had high risk for lung cancers. These are patients with no symptoms between 55 to 74. They were either current or past smokers, and they should have had at least a 30-pack year smoking history and no other prior histories of any cancers. Now, these 53,000 plus patients, they were divided into two groups. Group 1 had a CT scan every year for 3 years, and Group 2 had a chest X-ray every year for 3 years. Now, why did they formulate it that way? Well, because a lot of people got X-rays, and it was commonly used, even though it was not really the proven valid way of screening for lung cancers. And that's the way they're divided. So half got the CT and half got X-rays. Now, the easiest way to show the results of this study is to put it in a pictogram form, and it's depicted here. So out of the 26,000 patients who were screened using a CT scan, 24% of them ended up with a positive CT scan. So what's a positive CT scan? Well, it's any scan with a nodule that's at least 5 millimeters. So that means that 1 in 4 patients, 1 in 4 men and women walking around who are current or past smokers, 1 in 4 of them has a nodule in the lung. And that's a lot of nodules. So they then reviewed it at their tumor board, and if they felt that it was suspicious enough to warrant a lung biopsy, 10% of that 24% got a lung biopsy. And among those who got a lung biopsy, 60% of them had a lung cancer. And of course, among those who had lung cancers, majority of them were in stage 1. And of course, this is in contrast to majority of the patients we see in clinic who wait to have symptoms, where most of them are already in, stage 3 or stage 4. And so the chance of a cure is much, much lower there. So here, 63% of them were in a highly curable stage 1. So this was a landmark trial. And next slide. And the reason is that, next slide. So the reason is that, no, the previous slide, please. So this NLST trial showed that not only are they picking up lung cancer, but they are picking it up early enough to impact survival. In fact, those patients who were in that group who who were found to have stage 1, or along all of those patients who were noted to have lung cancers, they found a 20% decrease in mortality. That means that you are curing them by screening alone. And in fact, if you look at all causes of dying, all causes of mortality, there is a 7% decrease, as you can see here. Now, why is that? Because with this lung cancer screening, not only were we picking up lung cancers and detecting them at an early stage, we're also picking up, aortic aneurysms that we repair. We're picking up metastasis from other cancers. We're picking up emphysema and heart conditions. And overall, the patients in this trial had a 7% survival because of this screening. Next slide. And because of this landmark trial, the U.S. Preventive Services Task Force recommends the annual lung cancer screening with low-dose CT in people who meet all of these following criteria. So men and women between 50 to 80 years old who could either be currently smoking or used to smoke but quit within the last 15 years, and must have at least a 20 pack year history of smoking. And a pack year is equal to smoking about 1 pack or about 20 cigarette sticks for a year. So if you have been smoking 40 for 40 years, a pack a day, then that means 40 pack years of smoking history. Next slide. So now we know the importance of detecting lung cancers when they're early and when they're stage 1. But what do we do? What do we do when we detect them? So here we discuss the evolution of how we treat lung cancer surgically. So you can see here that it all began in 1891. Dr. Theodore Touffier, it's a French surgeon, performed the first successful removal of a lung, but that was not for cancer. That was for tuberculosis. And he did it by doing a posterolateral thoracotomy here. So it's pictured here in the upper left-hand corner, where we divide muscles of the chest, we cut one rib, and we spread the ribs apart. A few years later, Dr. Davis from London performed the first lobectomy for lung cancer. That's actually the first time that we've ever done surgery for lung cancer. And during that time, lung surgeries were performed in 2 stages. So stage 1 would just be to remove the rib, and then 10 days later, you would then do the second stage to remove the lobe. if you think about it now, it becomes sort of, primitive, right? 20 years after that, they then did the first single stage procedure. That was Dr. Graham. And then he did a pneumonectomy. That's in 1933. He used this posterolateral resection here. So you can see it's quite a big incision. That's in the bottom left. And with the rib getting cut and the rib getting spread apart for exposure, it comes with obviously more pain. It comes with a longer recuperation period. It comes with a slower return to work. But it was, in fact, the standard for many decades. And then in the early 1990s, the concept of thoracoscopy or VATS was introduced. This uses scopes, cameras, and little tiny instruments that now allow lung surgeries to be done without cutting or spreading a rib. In fact, in 1991, Dr. Roviero completed the first VATS lobectomy. So you see here that there in the upper center picture, you can see that there are multiple small holes instead of that large thoracotomy incision. So that translates to less pain, faster recovery, shorter length of stay, and then, faster return to work for the patients. And over the succeeding years, the VATS surgeons have constantly improved their practice such that single port or single incision VATS has become widespread, especially in Europe and in Asia, as you can see here. So in the bottom center picture, you can see there is only one to 2 inch incision, and through this hole, the removal of the lung cancer gets done. And also because there has to be constant innovation, right? There has to be constant improvement. In 2003, the first report of robotics in thoracic surgery was done. It was for 3 lower lobectomies, if I'm not mistaken. So you see here in the upper right corner that the surgeon gets to do the procedure from a console instead of standing bedside, and there's an assistant there that now exchanges instruments for the surgeon. And in the bottom right corner, you can see the incisions. And like with VATS, there's no rib cutting, there's no rib spreading here. The pain is less, the length of stay is less, and the recuperation is faster. And not to mention, there's better aesthetic results too when compared to thoracotomy, right? But it was also found that they have actually equivalent oncologic outcomes despite getting smaller incisions. And as such, minimally invasive procedures like robot and VATS, they have been since recommended by the NCCN guidelines for the surgical resection of lung cancer. Next slide. And since our screening guidelines get expanded through time, we will now expect to be seeing more and more of these smaller and deep lung nodules that are suspicious for early stage lung cancers. And the limitations of the current biopsy techniques that we have driven the development of complementary navigation techniques to improve the ability to not only localize, but sample and diagnose these small lung cancer. I'm sure Dr. Sethi will probably cover the diagnosis part in his talk, but here I will cover how we use navigational techniques to assist with surgery. Next slide. If you can just click on that video and pause it. Yes. Yeah, if you can pause it, please, Lane. So here you could see that there is a part solid ground glass nodule in the bottom lobe of the right lung that is deep to the lung. This will not be seen or felt during minimally invasive robotic surgery. So with the assist of navigation, we mark where this spot is using a software and sort of make a pathway to it from the main airway, from our trachea, all the way to this nodule. Can you hit play, Lane? So using this special catheter, we then advance to that bronchus and find our way to that spot that is now very close to that marked expected area of the nodule. And in this case, it's represented by this green dot. And you can see very clearly here that the catheter is only 1 or 2 millimeters from that green dot. We then deploy or inject methylene blue dye along with an ICG dye, and that will aid during the surgery portion. Next slide. If you can click on that video there, Lane. So in this video, you can see one of my partners here doing the navigation. And then, so he's using the bronchoscope for that and injecting into the area of the nodule in order to localize and mark it. And once the injection has been done, we then proceed with either a VATS or a robotic surgery. And that's what you see in the middle upper picture here. You can see that the dye marking stained blue on white light. And in the topmost right-hand corner, you can see it stained green when we shifted to near infrared light. We then remove this portion that lights up, that discolors with robotic surgery. And you can see here in the bottom picture that there is that part of the lung that came out with a blue dye in it. Next slide. So with all of these advancements in robotic lung cancer surgery, are there any more improvements expected in the future, right? You have seen the evolution of a thoracotomy, a big hole, into multi-incision VATS, to single incision VATS, and now we have multi-incision robot. Where is the early stage lung cancer surgery headed for us? Well, for us thoracic surgeons, the next frontier would be single port robotic surgery. Next slide. And why single port? Well, even if VATS or multi-port robotic surgery does not entail, rib cutting or rib spreading, there is still significant pain that most of the patients still require narcotics despite multi-modality pain medications. The image here shows that instead of multiple ports and incisions, it is now reduced to a single incision and there's multiple ports that go inside it. Next slide. And through this single incision, 4 ports can be utilized, as you can see on the left side, in order to perform lung surgery. In fact, in April of this year, stapling became FDA approved too. So now, theoretically, with this technology, we are now able to perform a lobectomy and a segmentectomy through a single subcostal incision. Here on the topmost right, you could see that a single subcostal incision there, and in the bottom, you can see a single intercostal incision. So we will soon be able to achieve the same outcome of surgery with better post-op pain relief, given that for subcostal incision, like the one in the top, we no longer need to work between the ribs. So the pain is going to be much less. I say it's the next frontier in thoracic surgical oncology, and I'm sure my colleagues agree with me here. And as of this moment, we do not have this here at Moffitt, unfortunately. The robotic thoracic surgeons, myself included, have been requesting for this to be acquired, and hopefully in the not too distant future, we will be able to offer single port robotic surgery to appropriate patients. Next slide. So in conclusion, lung cancer, as you know, it remains the deadliest cancer and tops even colorectal and breast cancer deaths combined. And if you wait until you have symptoms to get checked, it's usually diagnosed at a far advanced stage and will be too late for a cure. It is of utmost importance that we catch it early, and this can be accomplished by adoption of screening programs using a low-dose CT, which per the NLST trial that I presented shows that detection via screening decreases lung cancer deaths by at least 20%. Since most of these lung cancers are detected when they're stage 1. And with stage 1, there's definitely a higher likelihood for a minimally invasive robotic surgery, as well as lung-sparing resections in order to preserve quality of life. Meaning, we no longer have to take out the full lung or a full lobe. We are now going into sublobar resections. And most importantly, with stage 1, we aim for cure, right? And that's really what we hope to do for all of our patients. Thank you.
Well, thank you so much, Dr. Baldonado. That was a wonderful presentation and really fascinating to hear how techniques have evolved and improved over the years to really help patients and improve recovery and decrease pain, and that's fantastic. At this time, I'd like to introduce our next speaker, Dr. Sethi. Dr. Sethi is from our pulmonary department, and he specializes in interventional pulmonary procedures and is involved in innovation and new cutting edge procedures. Dr. Sethi, please take it away.
Thank you, Dr. Liu, and thank you for the opportunity to present today. I want to thank everyone who's joining us today this evening and spending the time with us. I'd like to kind of talk a little bit about, Dr. Baldonado kind of rightly pointed out how important it is to detect lung cancer in its early stage. And it kind of laid out so eloquently the advances in surgical aspect of it. But again, innovation is happening across the board. And so I'd like to highlight some of the innovations that are coming or are happening as we speak in early lung cancer detection. Next slide, please. So, like I said, I think it's really important to understand why it's so critical to diagnose lung cancer early. And I'll go over a little bit of that, but highlight innovations across the board, starting from our screening programs to when we detect nodule, what we do with it, and trying to overcome some of the limitations that have been present for years in terms of biopsying some of these smaller nodules particularly, and trying to get to what is the best course of action for a lot of these patients. Okay, next slide, please. So again, it's similarly to like Dr. Baldonado had mentioned, lung cancer accounts for majority of cancer-related deaths, even as of this last year. It is the third most common cancer, but accounts for the most cancer deaths. Like she had mentioned, it accounts for more cancer deaths than the next couple cancers combined. Next slide, please. Which is very important and unfortunate, because lung cancer is hard to detect in early stages because it's not likely to give any symptoms until it has advanced, which has always been one of the biggest hurdles in detecting it early. Unfortunately, people will not develop symptoms until the cancer has advanced, and so it's policy as well as screening programs that have been instituted to try to catch lung cancer early, even in patients when they have no symptoms. It's important for us to identify what are the risks factors for these patients and try to catch the patients that are most vulnerable to catching this disease. It's important because the outcomes are hinging on the fact of how early we can detect lung cancer. This is a little bit older slide in terms of outcomes. There's been improvements even in outcomes in late stage lung cancer, but we are still not at a point where early stage cancer, where we can reach the outcomes that we can reach with early stage lung cancer by treating them with either surgery, radiation, or a variety of other options. Next slide, please. So this is one of the measures. Again, what Dr. Baldonado had mentioned, that screening had shown significant improvement in mortality. And this slide kind of highlights to me not just lung cancer screening alone, but all the measures that have been taken over the last decade and the outcomes from that. So again, I pointed out the year in mid-2010s when the lung cancer screening was advocated for and got widely accepted as a means for detecting lung cancer early. You can see that other measures like smoking, cessation programs, and better treatments saw that the incidence of lung cancer was coming down. But when the lung cancer screening program was instituted, we can also see a little bit of split happening between the incidence of lung cancer, which is the lighter green line, and the cancer deaths that are happening per 100,000 patients being diagnosed with lung cancer, which is the dark green line. So both of them have lots of rooms for improvement, but we are, I think, certainly headed in the right direction. The momentum is there, and we need to just continue to push with these innovations to try to get better at this. Next slide, please. So next slide. So one of the question is, how can we get more people screened? So if you look at the data, unfortunately, the number of people who are candidates for getting lung cancer screening are only a fraction of them. Even if you are being very liberal with the definition of that, only in the teens to 20% of the patients who are eligible for lung cancer screening. The eligibility criteria, as mentioned by Dr. Baldonado, patients who are 50 to 80 years of age, who have smoked, are currently smokers or have smoked in the last 15 years, and smoke more than 20 pack years, are eligible for lung cancer screening, but only a small amount of patients are getting screened. One of the barriers, and there are multiple barriers on this, one of the barriers is patients having access to lung cancer screening. This may come as a surprise to a lot of people because you see a lot of radiology centers, you see a lot of hospitals across the cities, but unfortunately, this is not the case across all settings, particularly in settings we have healthcare deserts across the country where there are patches where healthcare is not as accessible as it may be in a bigger city or a bigger center. So one of the biggest hurdles has been patients getting to a appropriate lung cancer screening program. One of the innovations here is to take the screening programs to the patients. So Moffitt has been fortunate to have participated and have had the opportunity to get a mobile lung cancer screening bus, which is kind of shown here. And more and more places across the country are trying to invest into these mobile screening centers. The uniqueness of this mobile bus is that it's all in one unit. So you don't really, it's not a it's the size of a big a truck, if I may, but it can be parked at a lot more sites. It doesn't require leveling and can conduct these low-dose CT scans, which are needed for our patients to get detected, right? So I think this is key innovation. We've seen already more vulnerable patients getting detected, patients who were maybe underrepresented in the previous groups getting more screening, and this allows greater access to a lot of our patients. This has certainly shown improvement. Now the key is to try to make it even more accessible, take it further out from a certain radius that it's limited to at the moment, and trying to get it to more and more people. Next slide, please. Now, it's not just, so the other thing is when we screen, like Dr. Baldonado kind of showed, that about a quarter of the patients will have lung nodules. Now, not all of these lung nodules are cancerous. So our role as providers in lung cancer is to try to sieve out the patients that are truly at risk and that are truly suspicious lung nodules. This can be pretty challenging because there are certain features that set suspicious lung nodules apart, but they're not always obvious. And so with the buzzword being artificial intelligence, this has also been applied to lung cancer care. And this is one of the best applications for it, because this is allowing us to be more smarter about detecting the right lung nodules. This is still a little bit in its infancy in the sense that some of these softwares have been approved, but this is as learning models go, they're expected to continue to get better, more accurate, and more efficient, if I may. So the key role here is for the softwares. What they do is they look at the CT scan along and for first thing is that to highlight some of the nodules which may be subtle, may be easily missed, and avoid more human errors. So it reduces the misses for the radiologist. On the other hand, it also provides a better way to track these nodules. One of the biggest issues is once the nodule is detected, it's easily missed because people may not get the appropriate information. They may not get set up for appropriate follow-up. They may not be able to get access. They just may not be aware that they need that nodule assessed or taken care of. By using AI to better track these nodules, we avoid patients falling through the cracks and getting the appropriate care that they need. If it's about a CT scan that needs to be repeated down the line to make sure it's not growing or stable, then AI softwares can help with that as well. Next slide, please. A key feature, I think, in the slide before, sorry. One more point on the AI is integration of something called radiomics. Now, radiomics, what it does is when we look at a CT scan, the CT scan gives us a 3D reconstruction and the set of 2D images of the lung, but it's a set of 2D images that we're trying to make sense in a 3D world. And radiomics allows us to kind of get a better assessment of what the tissue density could be like, how or what it is, even if it's growing, is it growing actually in volume? Because these are 3D structures rather than actually just in one dimension. So AI can incorporate radiomics for better understanding and better understanding of these nodules. And this is, again, something that's certainly coming, a little bit early still, but it's getting better with each innovation. Next slide, please. All right, now that we have, if we are able to get more people screened, we get more nodules, and we are able to see through the nodules that are suspicious. The next key is to either get them to surgery or try to biopsy the nodules that we're not quite sure about, right? Pulmonary medicine has come a long way. In fact, like the first bronchoscopy, kind of the same timeline like Dr. Baldonado showed. In the late 1800s is when pulmonary medicine saw its first visualization of the upper airways. And that's the rigid bronchoscope that you see on the upper left corner that was first done to extract a foreign body in the upper airway. From that point, it took us almost I'd say 8 decades to get to the point of something called a flexible bronchoscopy, which allowed us access with a more flexible tube. That's the bottom left corner. Dr. Shakira Akita in 66 demonstrated this flexible tube that you could introduce into the airways and get further out. Over the years, we got better with our tools and biopsy. And the momentum, like I said, has picked up in the last decade or so. In 2018 was the first robotic platform for bronchoscopy that was introduced. Now, the robotic part, what it allows is, as the cameras and the fiber optics, we were able to get it smaller. It still was pretty hard to get them to maintain its stiffness, and they would be very flimsy. We would not be able to navigate with them as well. But the robotic platforms have allowed us to maintain our hold on those flimsy catheters while still being able to do the biopsy. This came out and it became even more widespread over the last 5 years, I would say, which most institutes now having shifted to robotic bronchoscopy for biopsy of these nodules. Even with that, we face challenges. We face that if we were able to get there, sometimes our breathing interferes with the accuracy of the biopsy, because if you're moving, it's like getting to the bottom of a moving target. So how do we compensate for that? The solution there, or the newer solutions that we are following, is introducing something called a CT scan. It's a cone beam CT scan, which is essentially our ability to do a quick mini CT scan with our needle in the nodule to confirm we are in the right spot and get the biopsy we need. Next slide, please. All right. So here's a little summary of where we are right now with the robotic bronchoscopy. Like I said, it allows us to get deeper in the lungs while maintaining control. It is a procedure that is done under general anesthesia, which allows us to control the breathing, prevent the lung from collapsing during the procedure, and it has improved our accuracy with biopsy. I'd say 6 years, 7 years ago, with the technology we had, our accuracy of biopsy was probably closer to 60%. So a little better than a coin flip when we went through the airways, but this has now reached closer to 90% or higher, which means that we have a more reasonable chance of getting the tissue we need and then running better tests at it. And this has been achieved by keeping the complications low. The biggest complication we worry about is collapse of the lung, and that has stayed closer to the 1% range in that situation. So really, the technology has come along that way to help us get better at biopsy while keeping it safe. Next slide. This is an example of a robotic bronchoscopy. The interface looks a little bit different, but the concept is very similar to what the system that Dr. Baldonado demonstrated as well. On the left, bottom left of the screen is the CT scan image, and on the bottom right is actually the actual camera that we are taking. What we do is we take the camera out into the different parts of the lung, and the software verifies that we are in line with what we have seen on the CT scan. This part is called registration. Once it's been able to do that, it is then able to generate real-time overlay. And as you'll see soon, on the bottom left, you'll start to see the similar sort of a picture as you're seeing on the bottom right. Now, the bottom left is the virtual image, whereas the bottom right is actual real-time image. One of the issues with the nodules is that the nodules are not inside the windpipe. They are in the sponge of the lung, so they lie outside the windpipe. So we can't always see them with our camera. So the virtual image helps us guide and gets us closest to that spot. And so once we are there, then we're able to run a few tests to tell us if you're right in the right position, one of which is the CT scan, like I said, and confirm that we're on location. Now herein you can see the blue line, much like the previous pathway you saw, we just follow the pathway that takes us closest to that lesion. So that's why it's called, sometimes referred to as navigation bronchoscopies, because it's kind of similar to what you would have on a GPS on a car, kind of guiding you to get to the destination. The light blue spot is the nodule that we need to get to. And so you can see we can't really see anything of a growth inside the airway. So we can get ourselves really close to the nodule, do our x-rays, do our CT scans, do any ultrasounds that we need to then be able to accurately biopsy. Next slide. So here's some examples. These are actually examples of biopsies we did over the last week or 10 days. I wanted to give the most recent ones. On these screens, the bright white lines that you're seeing, those are actually the catheters. So they can be seen brightly on the CT scans done during the procedure. The light teal blue or the light blue circles are the nodules. And then in at least the middle image, we can see a small white line come out into the nodule, which is the needle that we can see go into the nodule and biopsy. And I think the most striking part of this is all of these nodules are about 5 millimeters in size. So if I had to give a size reference, it's similar to in size as the back of a pencil. Bear in mind that a lot of these times with the breathing motion and things like that, we're still able to now accurately biopsy these. Next slide. So now that we've gotten so much better at getting to these nodules, the reason we are still facing a 10% chance of not getting the biopsies sometimes is that we're able to get to the lesion, but not always get the lesion into the needle that we need, or the cells in the needle that we need to. That can be for a number of reasons. It's just maybe nature of the lesion itself. Sometimes the cell, it's not easy to pierce a lesion, or if there is not enough cells in that area. So the next steps of innovations, which are currently happening, is trying to get better tools for biopsy. We often use the phrase in our field of work is it's not only important to get the tool in the lesion, but get the lesion in the tool. And so here's some of the examples of different tools that we use to biopsy. On the image A is the kind of tissue we can currently get with the needle. It's great. We get strings of tissue, but not always as structured as you see in this picture. Sometimes tissue dissolves a little bit, which limits the amount of cells that we can see. Image B is something called a forceps biopsy, which is basically plucking a little bit of the tissue. Now, the issue with biopsy A and B also is that they can cause a little bit of bleeding it's not significant enough to stop the procedure, but it is sometimes significant enough to interfere with our view when we look at it under the microscope. So the newer tools, as seen here, that's image tissue that we get with image C and seen in image D and E, is something called a cryoprobe. What this is, it basically freezes the tissue at its tip, and it works on the principle of it uses either liquid nitrogen oxide or carbon dioxide. The newer version uses carbon dioxide, and by turning it on, it instantly freezes at the tip, causing the tissue to get stick to it. And as you take the tissue, it comes out as a whole. So you can see well-rounded tissue in image C, and that is what has helped us get more cells with each biopsy. And what we are finding is that it's not increasing our complication rates, it's keeping it similarly safe, which is always our paramount concern. Next slide. So another example of the cryo biopsies that we are able to do, and the advantage of this is that wherever, in whatever angle you're in contact with the tissue, it's able to pull that tissue with that. So if you're touching it side on, it will still get the tissue. If you're touching it head on, you can still get the tissue. So it has been something that has allowed us to get even more yield in our biopsies. So trying to solve the solutions that we all face, and we learn from this because we hear from our surgeons, our oncologists, as to where we need to be to get better with our biopsies, get them the tissue they need. Because nowadays it's not enough to know it's cancerous. We want to know what is the makeup of the cancer, what is the genetics of the cancer, what kind of proteins it makes, and that allows us to be even more effective in our treatment down the line. Next slide. And I think that's all I had. So I'm glad innovation is happening across the board, from detection to biopsy to surgery, and certainly even in treatment. All the frontiers, I think, are moving in the right direction together. Thank you.
Thank you. Thank you, Dr. Sethi, for a wonderful presentation. The pictures are worth 1,000 words. Seeing that cryo probe, I've heard of the cryo biopsies, but until you see a picture, you don't fully understand it. That's really really fascinating. And the fact that it can increase yield is fantastic. Well. At this time, I'd like to take a moment to introduce one of our partners here at Moffitt, Mr. Mark Ketterer. Mark is with the Moffitt Foundation, and he partners with the Thoracic Program to ensure that we receive the research dollars we need to get clinical research off the ground and to continue to make advances in cancer treatments. If you would like to learn more about how you can help, please contact Mark to find out more. Mark, would you like to say a few words?
Sure. Thank you very much. Thank you to our esteemed panelists, and also for all of you for joining us. It truly is my pleasure to work with these physicians to ensure that they're receiving the philanthropic dollars necessary to take these research efforts to the next level. As you saw tonight, screening is incredibly important, and due to a philanthropic gift, we are actually able to have this lung screening bus. And I'm going to jump ahead, Dr. Liu, because I see one of the questions there actually referring to the lung screening bus and how much does it cost to be screened. And if you, from my experience and working with that team, as long as you fall and your insurance falls under those screening guidelines, it's covered by insurance. But also the Moffitt Foundation is working together with donors to sponsor the bus to go out to areas that may not typically have the insurance requirements, or they may be outside of our network and working area. So it's another great project that we have going on in the foundation now to ensure that we are truly screening as many people as we can. So thank you for joining us today, and I'll let you, Dr. Liu, jump into the Q&A.
Oh, great. Thank you. Uh, well, we thank you, Mark. We definitely appreciate all that philanthropy does to make research possible. Ladies and gentlemen in the audience, we invite you to ask any questions you have to our speakers tonight, and you can type your questions in the Q&A box at the bottom of the screen, and I'll try to read the questions and to invite the faculty members to answer them, including myself. I see one of the questions has to do with commenting on recent news of possible benefits of the mRNA COVID vaccine when patients are receiving immunotherapy. And the question is, what are we advising patients to consider getting the COVID vaccine within 100 days of starting immunotherapy? So I believe that question is alluding to recent reports of benefit, and if someone is receiving immunotherapy and they've had a COVID vaccine within 100 days. It's a very interesting, fascinating observation, but it is an observation. These are observational studies. So I don't think we would be at the point where we would say there's proof that it's causing that, but it would certainly be reason to consider doing more studies to try to verify that. So that being the case, as one reason I'm answering it is as a medical oncologist, we are the ones giving the immunotherapy for in various situations. So I don't think we are yet at the point of making that a recommendation, but it's just a very fascinating observation. And there's another question about outside, I guess, of surgery and I guess what Dr. Sethi has reviewed in terms of innovations in interventional pulmonary. What are other new promising treatments? Well, I don't know if I have time to go through all of them. There are, of course, there's so much research and advances, and we've heard about surgery, interventional pulmonary. We don't have a colleague in radiation here, but I know innovations in delivery of radiation is another area of a lot of research. I can at least comment in terms of new drug therapies. There's also a lot of exciting research which lead to approvals of new drugs. So there are a number, I think, besides immunotherapy, which are the drugs that try to harness our immune system, typically working on our T cells to try to attack lung cancer. There are a growing list of what we refer to as targeted therapies. And this is as research better defines specific targets in lung cancer cells. And many of these are specific gene mutations or gene rearrangements. Studies have been done to try to develop drugs that target those. And in general, I would say those types of treatments have been more successful or have higher tumor response rates than traditional chemotherapy. So I would say immunotherapy and then targeted therapy are areas in medical oncology where there certainly has been a lot of encouraging research and new drugs and treatment options for patients. Let's see here. I see one question regarding subcutaneous immunotherapy, which is that's pembrolizumab or Keytruda. So I would say that I think eventually the use of subcutaneous treatments will become more common. I would say, and that's both in what you mentioned, immunotherapy, but there are other IV treatments which they are developing subcutaneous formulation. So that's certainly something to speak with your doctor about regarding those options. There's another question regarding stage 4 lung cancer and I believe surgery. I think I can defer to Dr. Baldonado, but I think in general, the approach for stage 4 lung cancer, which means cancer has spread to other sites, different organs, primarily drug therapy will be tried first. But I know there may be some situations where it may be reasonable to consider surgery.
There is new data for what we call oligometastatic disease, where there's maybe one or only a very few areas of spread of disease where there's benefit to actually removing the cancer. But that means the patient would have to undergo systemic therapy first and make sure that there are no further increase in the lesions before we subject the patient to a high-risk surgery for a stage 4 patient.
And I do see another question about treatment of has to do with pleural effusions. I don't know if you want to tackle that, Dr. Baldonado.
Yeah, for sure. So really pleural effusions from malignancies are only treated whenever they are symptomatic, right? So if the patient is coming in with symptoms, you have to palliate that symptom, relieve the patient of that symptom of shortness of breath and pain by draining that fluid. So there are many options, like the usual that we see in clinic would be draining it with a needle called a thoracentesis. That's usually the first option. And when it recurs and it's biopsy proven to be positive for cancers, then there is that Pleurex catheter placement, which is a small cuffed silicone catheter that is tunneled underneath the skin, and it allows the patient to just drain that fluid by himself at home until it's no longer draining, and then we can just remove it once it's no longer draining. The third and the most invasive of the treatments would be what we call a VATS pleurodesis, where we subject the patient to anesthetics, be it general or IV sedation or minimal, sedations. And we make several small cuts and place a camera and actually drain all of that fluid, then pleurodese with talc or doxycycline or iodine. So those are ways to really decrease the chance for recurrence, and that's the one that's proven to be most effective in terms of pleurodesing to decrease the chance of it to ever come back. In fact, the effectivity is about 92%, but unfortunately, it's subjecting the patient to risks of general anesthesia or IV sedation, and that's the one thing, the downside to it. So most of the time, though, a Pleurex catheter in itself can already address it. In fact, there's a pleurodesis rate of about 30% with Pleurex catheter only, which is something that could be inserted at bedside or even in the clinics. And there's also a question here about what AI platforms are Moffitt currently using in the tailored treatment for lung cancer. So the institution, I think, is considering getting the software in order to read radiology or CT scans with very small nodules, and more importantly with surgery. We're trying to see if we could use a software to guide us in terms of resections for segmentectomy. So we're trying to explore possibilities of aiding the surgery with a software to really point to where the lesion is and what branches are supplying that, what veins are draining it, so that we can be sure at the end of that surgery that we are resecting it with good margins, and that the vessels that need to be divided are the ones that get divided. So that's something that we do in surgery. I'm sure Dr. Sethi has points for AI too in IP.
Yeah. So, I mean, for AI currently, we are vetting a few softwares. Like I said, there's some that are approved by FDA, but they're conditional approvals. And so we are trying to make sure that the software that is best suited to workflow comes through. And so this software would Potentially the benefit would want to be that we can use it in our clinics when we see patients who had scans outside Moffitt and even assess those and help our radiologist as well. From the interventional side, there are currently AI integration that is being assessed for even the robotic bronchoscopy. So similarly, kind of improving the correlation between the virtual image and the real image. There's potential for AI to get integrated at that level as well, which is still under development, not quite there yet, but it's coming soon as well. Those are the two big areas that we would want to see AI integrated at.
I see a question regarding a specific question about therapies for ROS1 gene mutation, which is one of the potential targetable gene fusions. And I guess I'll just add there are new drugs being tested in trials, but the most recent drug would be begins with the T's and Tom, taletrectinib. So that's certainly something if that were relevant to you, you could speak with your oncologist about one of the newer next generation drugs for ROS1. And I see a question about the stage of lung cancer, about if it had spread to the femur and that had been removed, would that change the stage? I'll just comment that stage really refers to the extent of spread of the lung cancer at diagnosis. So stage really doesn't change. So it would still be referred to as that stage wouldn't change. I see a question about after surgery, when does one have to be scanned? I think in general, most guidelines will say to scan somewhere in the range of 3 to 6 months after surgery, but it would depend on how concerned your doctor is on your risk of recurrence. Let's see. I have a. I see a question of someone who's been treated for stage 3A lung cancer last year, and they've had clear CAT scans, but had a question about cough. Well, certainly, that's something you should speak with your physician about. But I know cough can be caused by a number of different things. Even if the cancer's been treated, whether for stage 3A, most people are either having combinations of chemotherapy and radiation. Some of them may have surgery, but I think many times there are, even after treatment, there can be cough. But certainly, it's something we would encourage you to speak with your doctor about. Now, one question is a specific question about immunotherapy, Keytruda or pembrolizumab. I believe they're referring to a patient who has been on that for, I believe they meant to type in 4 years, but that their doctor's recommending stopping it. It sounds like there are issues with allergies and asthma and coughing. Well, I guess I would say that is for something that specific. Again, we would defer to your oncologist. But I will at least say that there are a number of guidelines in studies where patients who were on Keytruda, that they did actually give a break after 2 years. So if someone who's been on it way past that and they're having any potential side effects, it would be very reasonable to consider, holding that. But again, I think this is something you would need to talk to your doctor about. And there's a question about someone who's had a thoracentesis, but they have not been notified if the fluid has been tested. I think that's certainly something you should contact your doctor about. It sounds like
Yeah.
your question is if there's been cytology results for that. So it doesn't take that long. I think often within 24, 48 hours, you'll get at least a preliminary report. So you could always contact your doctor or your clinic to get answers about that. Well, I think that we are just at time. And I really want to thank the audience for your thoughtful, wide-ranging questions. If there are any questions that we're unable to get to tonight, don't worry. Our staff can help us review those and get back to you afterwards. So otherwise, that will do it. Thank you for being with us tonight. We hope you found this webinar informative. We certainly appreciate your continued support as we work to revolutionize cancer care and provide the best possible outcomes for our patients. Have a good night. Bye-bye.
Good night, everyone.
Bye.